Well, hello. I am Delaware State Representative Paul Bombach, serving the 23rd House District, which is in Newark, West and North Side. And it is time for another weekend update on Delaware's retirement health benefits system. It looks like we are live now. Good. If somebody is on this, actually not yet, please let me know if you can hear. Here. Okay. So it is time for update. We've had a meeting on Thursday. It was energetic. There was passion expressed, both by the members of the subcommittee and also by the attendees. The public comment at the end was also quite spirited. So it was a good thing. That's why we have our public comments. And public meetings for that matter. So as I normally do, let's go through the various presentations that were made, and we will start off with the primary presentation, and I will go there. Okay, that's not the one I wanted now, so let's try that again. Why is that one there? Let's try that again. Close that out. Bring that up. Oh, no, isn't that interesting? Okay. So we're going to change that to take that guy out, and we're going to slide stop screen. Present. Slide share screen. We want to select. And we want screen 1. Nope, we want screen 2. Okay. Hey, just a little bit of tech. There we go. And then we bring it up. There you go. Okay, so this is the presentation we had on Thursday. One of the two presentations. We'll go through them both. There was actually a lot of this, almost a large amount of this was a repeat from the one 10 days earlier. And we had a little bit more information to go over. There's a second presentation also. So let's go through this, and I think we'll be able to see more of it if we go to that mode. Okay, so so we started looking at combinations. I'm sorry, no, we're going to start looking at, these are funding options we've looked at, and what is presenting is the first thing is we have a baseline. We already are at the point of having close to 18% of the gap filled. And what's the gap? And what's OPEB? OPEB is other post-employment benefits, and primarily it's health benefits the state has promised to our current and past employees upon retirement. So OPEB is what we call that, and that gap, the gap is somewhere over $8 billion when you look in the future, about 30 years in the future. So we're trying to figure out how to address that. Actually, it's like 30 billion in the future. In today's dollars, it's about $8 billion. That sounds very large because it is. And therefore, to address it, we need to take some large steps, which we're doing. And those large steps, one of the foundations of them is that we're going to take steps and keep doing them year after year after year, actually decade after decade after decade, probably 30 plus years to close that gap. Where we are between our promises and how much we've already set aside is we're about 17.8, we'll call it 18% already there. That's our baseline. And that's from different funding that we've put in over the past many years. So that's our starting point. So then everything we're looking at afterwards is, well, except for one slide in the future, is going to build upon that baseline. There is discussion of that no longer should be the baseline because we've taken a step last month in the legislature signed by the governor to shoot us forward to around a 60% current baseline based on what we've accomplished there. So what this looked at, and actually this is the first choice in here is that 1% additional funding you see. That is what we put into place, Senate Bill 175. Now it's the law. And what that does is it takes 1% of the budget, and the budget generally grows by 3.6% is what the average has been. It grows each year with inflation. And so that's $50 million today. Well, 48 before, it's around 50 now, it keeps growing, et cetera. And that by doing that for over 30 years, we will narrow that gap from the current 18% up to about 60%. So, half the way there, more than half the way there, still some more to go. If we did more than that 1% of the budget, we get there, we close the gap more. But there's trade-offs, because when we take it out of the budget, it means those are dollars that aren't available for other spending within the budget. What do we spend in the budget? Well, we take care of, actually, healthcare is a big piece. Current employees. We also have all of our state service centers. It pays for Medicaid, or at least the state portion of Medicaid. We just have a whole lot of health facilities that the state provides dollars for. We also pay a lot towards our public schools. We pay a lot for just a whole lot of things. We've got our state police, National Guard, all kinds of different things that we do within the state that cost dollars. And if we were to direct more of those dollars to this OPEB fund, first thing is we'd close the gap very well. And number two is that those would be dollars that wouldn't be available for other things that we would like to do. So big trade-off. What we chose at this point is to do the 1%. Gets us a good progress towards that level of closing that gap. So that's the first things. We have those three there. The next slide shows we've talked about three different ways of adjusting who is eligible for retiree health benefits and what payment might be required. You can see in the first one, the change would be to make it so that a retiree's spouse, if they need them to be covered, they'd have to pay a 50% share of that. Now, anytime you make changes, there's a whole issue of who's grandfathered, as in who doesn't see the change and who does see the change. We have three models of looking at. One is that model A is those who haven't even been hired yet. So we make the change so that nobody will have been, so that when you're ready to get hired in 2025 and beyond, the change is made and you will be told, we've got a retiree health. And by the way, if you want your spouse covered when you retire, this again, you're talking to a 21-year-old new hire. So when you retire, for your spouse to be covered, you're going to need to pay half of the cost. The state will pay the other half, and we're paying essentially all of it for you. So that's model A. Model B says this only applies to new hires and those who have less than 10 years experience, those who are hired after January 1st of 8 years ago, 2015. So it says, those who have less than half of their career behind them, so they've got plenty of years to make adjustments to prepare for this change. That's what Model B is. Model C is this is only for future retirees, those who retire 2025 and beyond. But this could include someone who's been working for 28 years, 38 years. But it says that it's not, if you notice, all three of these are, if you are currently retired, no change. Reinforce that because it's really important to retirees and it's really important to the subcommittee. If you are currently retired, none of these potential eligibility changes would apply to you. You are grandfathered. You will see no changes. So there's four different ones. One has to do with how many years of service you have affects what your payment level would be, and it lengthens it so it takes more years to have the state cover more of your health costs. So you need a full 30 years for the state to pay 100%, as an example, and full 20 years only gets you 50%. So it adds a few years to the current schedule in there. There's this issue of term vested, which means there are those who have enough years to have a pension in the future, but not the date they retire. Let's say somebody works 20 years from age 21 to 41. Yes, they have enough years, I believe, to be vested and to have pension benefits, but it won't be payable when they retire and they're 41. It will be payable at a future point, 60 to 65, somewhere in there. I hate the term, and I think it's pretty darn unclear. But the concept is, if you have somebody who retires from the state early and may do a second career, a third career, not second employer, third employer after the state, then they would not have health benefits because they weren't working up to their retirements. The concept is it's the last employer that is responsible for the health benefits for that individual. And so that has that would be a proposed change. And then the last one listed is you only get your health benefits starting at age 60 or age 55 for state police because they're mandated to retire by age 55. Um, this is related to the previous one. There are those who work for a while for the state and then work presumably for another employer or two. And this says that, well, currently, if you are vested in your pension and you are eligible to receive it, so let's say you put 30 years in, you still could be pretty young. You could have started full-time work at a high school at age 18. You could be 48, be eligible for your pension, and currently be eligible for health benefits, which means we have 17 years from age 48 to age 65 of paying all the costs for your health benefits before Medicare comes in and pays 80% of it. So the state is on the hook for a long time for all of the health benefits. And I think there is the concept that we've had in our country, especially since Medicare, and for that matter, Social Security, that retirement and employer provided, for that matter, federal government provided retirement benefits start at age 65. Normal retirement. Sometimes there's early retirement for Social Security. It can be as early as age 62. So this last potential change would say that health benefits also don't start when you retire from the state, but they start at the later of when you retire from the state or you reach a particular age, maybe 60, maybe 62, maybe 55, maybe whatever, 65, whatever. So that's the fourth one there. And I'm not spending too much time on it because I've talked about it before and because the subcommittee has not come to any conclusion. And frankly, I'm not hearing a large amount of desire to incorporate one or more of these. We might get there. We have a few more meetings. We'll go into what's next in just a bit. There's also changing the health benefit plan, the structure of the plan. So we currently have a Medicare supplement plan. It is called MedicFill. That's the version we have. The state administration last year voted or chose to change that to Medicare Advantage, another kind of retiree health plan that was stopped from a lawsuit with a judge's order. And then another way to go is to use a health reimbursement account where retirees get a certain dollar amount every year, and then they can choose what health benefit to buy out in the marketplace. So there's many ways to do that. The two that we modeled was you get $5,100 in the first year, and then we increase that 2% a year to cover rising costs. The other one is you put it in 4% a year. And we've pretty much said we're not interested in this for reasons that frankly don't matter. You can always send me an email and I'll get you information on why that is. But HRAs don't seem to be on the really under serious discussion by the subcommittee at this time. So this is one that looks at, I guess, a bit of a combination. What it says currently, retirees pay either 5% or 0% if they had enough years. And if they have enough years, it's 100% if they retired before 2012, and it's state pays 100%. The state pays 95% if you retired after 2012 or later. And this says, well, we're going to boost that up from the retirees portion. It was 0, it became 5%, goes up to 10%. And that's something that can raise some dollars and close the gap a little bit, or maybe raise it to 15%. And again, raise some dollars, close the gap a little bit. So again, you can call that a benefit design change. So as opposed to it's not funding from the state, it's funding from the retirees, and it's not an eligibility. You're still eligible. You just have to pay a bigger share. So that's we did model that also, and each of these are sort of individual elements, and then we're going to start combining them in just a minute. So then we had and let's back up. The previous one is based on some Medicare supplement, like the MedicFill that we have today. So it wasn't changing that overall plan design, it was just changing the cost to the retiree. So then we look at, well, what if we actually change the format? We looked at HRA, not too interested in that. This is a Medicare supplement with a higher share cost from the retiree. And now we have one of what if we did Medicare Advantage as was proposed by the administration last year. And here what you see is that it's the same. It's essentially the same thing that's proposed before. Although let's back up. This is all current retirees unchanged. They're grandfathered. They still get the supplement, and they have to pay either 0 or 5%. And then but then this said, well, Medicare Advantage for all new retirees based on the grandfathering, the three different models: those who retire after 2025, those who are hired after 2020, I'd say after 2024, those who are hired after 2024, or those who were hired less than 10 years ago. But all current retirees, no change. So that was modeled. So we have that information also. So what's the next thing we look at? Another way to do funding that we saw was there's this thing called OEC. And is it listed here anywhere? No, it's not. But what it talks about the rate of payroll. So OEC is other employment costs. It is applied to every state employee. It takes how much they're paid, their salary. And currently we take 0.36% of that, less than around a third of 1%, and put that towards the trust fund. What this says is that we would increase that to 1%. And that actually has a pretty darn meaningful closure. It's a 7.7% difference. Doesn't sound like a big difference in funding. It's a pretty big difference in closing the gap. If we go back, remember the 7.7%, okay? We go back and look at the other choices, the other things we've already looked at, and actually the Medicare Advantage is one of the bigger ones. The most impact it has is a 7.7%, and that's where you're applying this to current employees who have not yet retired, but those who retire in 2025 and beyond, just less than 18 months from now. And the most it does is 7.7% difference. So that's as far as percent of the funding gap, the percent of payroll, that OEC, going up to 1% has the same impact. And all the other ways to do to grandfather in Medicare Advantage does less than what that does percentage-wise. These differences, less than 2%. This is the changing the share to 10% and 15% for the retiree to pay of their premium. Now, this one actually has a 12%, but this is an HRA, and the 2% increase is frankly terrible for retirees, which is why the subcommittee's not too interested in that. But if we really wanted to put lots of stuff on the shoulders of the retirees, we would do HRAs with 2%, and that would save a bunch of dollars for the state. But again, I think it's pretty draconian on retirees. All these changes, which is the eligibility changes, that 4 different categories, the most it does is 3%. Remember, the percent of payroll going up to 1% does 7.7, so more than twice the impact of any of these individual ones, and actually 7 times the impact of some of them in there, 10 times the impact of at least one of them, or I guess 2 of them. And then the funding rate certainly has a big impact, but we've already chosen that first one, which does an individual impact of 42%. You add that to the 17.8, and you get up to essentially 60%. So let's go back. We've got 7.7 on the payroll. So we have all these individual ones. Now, what if we start combining them? So this one says we're still doing a Medicare supplement, like MedicFill, and a 15% share for the retiree to pay towards the premium. This still has a grandfathering. This is only for new retirees as of 2025 and beyond. With that, no other change in there. So what this saves is around 2.2%. So if we do that going up to 15%, but keep a Medicare supplement, a 2.2% difference. And then this is one where we're also going to offer Medicare Advantage, and then retirees have to pay up for the difference between Medicare Advantage, which is the least cost to the state version of a medical plan, and the Medicare supplement like MedicFill. And so current retirees, you get it for 5%, what you already have, or even 0%, depending on when you retired. But then if you haven't retired yet, you retire after 2025, then based on your age now, then you either pay, it's 60, it's still, then you pay 30% if you're not yet 65 at this point. If you're younger still, then you would end up paying 55%, 80%, and 100%. So it increases so that in time, our future retirees would have to pay the complete difference if they want to keep a Medicare supplement. And they would always be able to get the Medicare Advantage for that 5% of the cost level. So that was a combination that was presented. This is a combination where we're doing the 1% funding, which frankly we've already done, and then a 50% spousal share, and then we keep a Medicare supplement. And what it does is a total of 64%. Remember, we got there 60%, so the spousal benefit gets us a few percent more than that. And then we come down. So this is one where that payroll cost, we said it's currently 0.36%. One proposal gets us up to 1%. This says we're going to go up 1% a year. And we're going to get to adding 2%, or adding 1% up to 2% by 2026. And then each year add one more until we get to 10%. That gets us, frankly, past where we need to go as far as the filling the gap of the fund between promises and funding. So it's pretty clear we don't need to go that far. And this doesn't even this does not include the 1% of the budget, which gets you by itself 42%. So this is really, I'm going to say, overkill. So we've asked that they cut that back and get us something more tailored to not overshoot our goal, because this is a little bit draconian. This, as far as this takes a whole bunch of dollars and obligates the state to get those extra dollars in there, which is why it does more than it needs to do. So it is a good first step. So there's another combination. So we're doing 1% of the budget. This is what we've already done in law. And then the protected growth, okay, additional 0.5%. Okay, and this says we want to get that payroll cost up to 10%. We're going to go slow. We're going to do it over 20 years, go up in 0.5% increments rather than full percent increments. We're still going to do that spousal. You pay half of the cost for your spouse to be covered. And we're eliminating the vested retirees. Those are people who leave employment from the state before they're old enough to receive a pension, and therefore we'll let their next employer take care of their medical costs. They've earned their pension, not doing anything to that, but it says they would not receive the healthcare benefits. For some reason that I do not understand, this was modeled using Model B, which is the it's those who were hired less than 10 years ago, 2015 or later. I don't know why they didn't choose hire date after. Maybe they just mislabeled it, because hire date. No. Hire date, future hires. They did it for future hires. Okay. And retirees pay 15%. New retirees pay 15% of their of the premium each year. So up from 5% to 15%. All those together get you up to 80%. 80% is a good number. And frankly, I'm a little surprised it's not even more than that. But regardless, that's, that was run. And so then we went through that stuff. We looked at this slide. Frankly, we had some heated discussion about this. This and the implications of the next one. So at the last meeting on July 10th, Finance Secretary Rick Eisenberger spoke about this issue, and the issue he raised was, we in the subcommittee, and frankly, this was at the first meeting, and I spoke up and I said, I'm a numbers guy. I want to see what number we're trying to change. I want to know what our goal is. And I said, I've looked at all this, and in my mind, we should be looking at the gap between our promises and the money to meet those promises. And we want to narrow that gap. We want to cover a certain percent. And frankly, I need input from the experts to say, should we be shooting for 100%, 90%, 80%, 70%, or whatever? For what is actually, the subcommittee on Thursday voted and said our goal now for this subcommittee for its current actions is 80% funding level. 12, 13 days ago, the finance secretary said, well, that's good. You should be looking at that. You should also be looking at the dollars that are going towards that year's retiree health benefits. And he's right. We should be looking at that. His timing is wrong. And sorry, my opinion, and I stated this in the committee, is that's an important issue. And the reason is it does, if our retiree health benefits each year goes up and up and up, then what we can spend in the budget for other things goes up slower or even can fall. So it does crowd out other things that we'd like to spend money on. However, this is now July, and we started in March. So we've got 4 months in, and now we're being told, oh, you were looking at A, you need to be looking at A plus B. If that was raised in March, I'd be all in. We're near the finish line. It is too late to bring in a new fundamental thing we need to be focusing on. That we can look at that in the next wave, but right now we have an awful lot of data that focuses on what no one disagreed with, that we need to look at that funding percent. So if you look at, there we go. Look at all these things here. They don't have what the funding, what the dollars spent out of the budget is each year in these. So if that's so important, then we need that data. We do not have that data. It is July. We should be finishing our work at the end of August. It is too late to get that data for this. So sorry, glad you raised it. It is important. We do not have the data. We don't have the time to get the data for all that and make and add that as a factor that we are driving our decisions with. Obviously, Finance Secretary and I disagree on this point, but regardless, I shared my opinion that it was too late to add an additional goalpost to be focusing on. The following slide here looks at two different scenarios and how the percent of budget goes. Actually, it doesn't show you percent of budget, which actually annoys me, disappoints me, because the previous slide showed you how the dollars rise, but even though it's rising, it actually takes a lower percentage of the budget because the budget's rising, at a similar level. So that gives you context. Dollars rising is important to see, but I want to know how that relates to something else, percent of GDP, or in this case, percent of state budget. That's what the orange line is. This one doesn't even give you that. It doesn't give you that context, doesn't give you that perspective of what that rise is, other than by putting 1% of the budget and 0.36% of the payroll, which is, this bottom slide is what we're doing right now. And what you see is that we're not seeing a real increase in the overall liability, but we also aren't cutting it back. Well, we know we haven't done enough. We know this only gets us 60% of the way. So anyway, I found these two slides to have too little information to be actionable. And the previous slide raised an issue that, yes, there's more data out there, important data out there, but it's a 2-minute warning of the fourth quarter. We're not now saying, oh, by the way, we have an additional additional goal line that's further down into the stands that we need to be focusing on. So sorry, I was a little bit heated on that point. I want to note that two things were added here. We now have the dates we had the times for the next two meetings from 1 to 3 p.m. on August 10th and from 10 a.m. to noon on August 24th. It will not surprise us if we have a third meeting in August, but we have no date or time set at this point, and we may have to go into September. So what remains to be done is for us we have all these choices, and we haven't run, and if we looked at each choice and then ran every combination possible, we'd have thousands of combinations. So what we're going to be doing at the next meeting, different from what it says here, is say, we really want to narrow stuff down and rule stuff out. So are we going to leave the percent of budget at 1%? Probably yes. What do we want to do with percent of payroll? We've asked them to run some more numbers and not overshoot the goal, and also to assume the baseline of 1% of budget. So maybe it maxes out at 3% or 4% rather than 10%. So we want to look at that and figure out what we want to use for that. We want to look at those 4 eligibility changes: spousal, term vested, age of retirement, and a fourth one, spousal share, whatever. There's 4 ones there. Do we want any of them in the combination? And any further plan design changes? Do we want to increase the percent share? Do we want, and actually, we'll see this in the next presentation. We want to identify what limited number of new combinations to look at, and then we want to take some votes and say, this is what we think is the best thing. We hope it's going to hit our goal, our agreed upon goal of 80% of the budget gap met. So that's what we should be doing at that August 10th meeting. I hope you can join that. This is that payroll cost. OEC is what which stands for other employment costs. And again, you see that currently we're at 0.36%. It had been higher before. It's been 0.36 for a while. And then we also, the pay-go, this is when we pay someone $50,000, not their money, the state also sets aside 9.21% for that year's retiree health costs for the future, for the past employees. Because this is percent of payroll, so percent of the payroll for current employees goes towards dollars for that year for people who have already retired. Anything else in here? Frankly, this is that your share keeps rising in that one scenario where you have Medicare Advantage and Medicare Supplement. Medicare Advantage is at that 5% level. You have to pay up if you want supplement. This is for future retirees, not current ones. They're grandfathered. But it's another slide of that. And so that's all the first presentation. Boy, that took a long time. Okay. So we also saw this presentation. This was not available before the meeting. It was presented at the meeting. There's 2 additional slides in here, and I'm really glad they added them, and I'll mention them in a sec. So there are many different versions of Medigap, Medicare supplements out there. The current health benefit program we use, we call it MedicFill. It's really patterned after Medigap F. And F, as you see, has a lot of zeros. What's that mean? It means no out-of-pocket for most things here. So no deductible, no co-insurance, no co-pays, all that sort of stuff. So it is it has the best coverage. You cannot right now, if you're newly retired, you can't get Medigap F. You have to have been born. You have to have been born before you have turned 65 before. So Medigap G is pretty close to it. I think it costs an extra $226 a year. Everything else is identical between F and G. Again, our current one is patterned after F. But then there's other ones which would cost you less or would cost the state less. And then the person who's covered, the retiree or their spouse, would have some greater share out of pocket. So this looks at, and there are out of pocket maximums on things. So I think we're gonna look. I think it's L and M. We're gonna G. Geez, we'll see in a sec what they've modeled. So, and we asked them for this. We said, okay, maybe we're not saving enough money, and rather than go to Medicare Advantage, what if we just go to a different supplement for future retirees? So let's look at a few and see where we go from there. So this is more of firefighter before. Okay, don't worry about this. So actually what they originally showed is this, and this upper right shows 50th percentile. This is the average person projected based on how our Delaware retirees have used the MedicFill program in recent years. We project what if it was under Medigap N, Medigap L, and what you see for the average employee, under MedicFill, you're paying somewhere between $400 and $670 a year. Most of that is your prescription cost. If you're paying 5% of the premiums, that's another $276. So let's say it is under $700. Average one would pay about $1,500 under Medigap L and close to $2,000 under Medigap N. How they computed this and how they priced it, I can go into, but let's not get into that detail. But again, this is the average person. What about the average healthy person? Well, the average healthy person would be paying less. Their prescriptions are less. And therefore, what you find is that it costs the MedicFill, the typical recent retiree, close to $500, about $1,100 under L, $1,700 under N. So if we wanted to share the cost more with the retiree from the state, then we can go to L or N and get different results. And then what about somebody who's has 90% of people who have lower costs than them in retirement health in the state? So here what you see is more prescriptions, even for someone under MedicFill, so around $800 a year, around $2,200 for N and $2,800 for L. So what you may notice is L used to be cheaper, and for the average person, for the average healthy person, but for the average unhealthy person, N is better because it has lower caps on things. So it's one where you could look, if we did this, you could look at it and say, well, you know what, I do have a lot of pre-existing conditions. Maybe I have diabetes, and maybe I've got blood pressure medicine and some other stuff. So maybe I want N to make sure that I never pay more than a certain amount. That may be a good decision for you. Or you may say, I'll pay the difference and I want to keep something like Medicare F and G, such as the current Medicare system is. So we asked for this, and we really appreciate this stuff being there. They're going to make some adjustments to how they present it at the next meeting. So this is, when we talk about difference in plan design, we were presented with, switch everyone over to Medicare Advantage, like that. We looked at, what if we all go to HRAs? If it's 2% or 4%, okay, whatever. But we never really looked at, what if we change within the Medicare supplement? Because one of the things that people really don't like, the main thing people don't like, we've heard, people don't like about Medicare Advantage is that you have to get pre-authorizations and you have to be in network. Well, if you have a Medigap program, a Medicare supplement program, pretty much almost everyone every healthcare provider will accept Medicare. And if they accept Medicare, they're going to accept Medigap. But they aren't necessarily going to be in the network to accept Medicare Advantage. So that was one of the big things we heard from the retirees when the Carney administration proposed, change the system to Medicare Advantage before it got stopped by the courts, was we like Medicare. Don't make us give up our Medicare card. Don't make us give up the ability to go to any healthcare professional who accepts Medicare, which is everyone. We want to stay in that. So this does that, but still shares the cost a bit with the retirees. So, okay, good to have information. Nothing else there matters. So, okay, I'm sorry, I don't want to spend too much time on that one. I want to mention a few things, and then, by the way, we're not getting any questions, and it always worries me. One of the points that I had raised at the meeting on Thursday was the change that the SCBC, the State Employee Benefit Committee, made last year from MedicFill, a Medicare Advantage / Medigap program, into Medicare Advantage, only affected Medicare age retirees, 65 and older. It never changed a thing for pre-Medicare retirees. So it said, we've got this big gap of funding, and we're going to solve that by making changes only for the benefits we provide to people who are 65 and older. What about people who are less? Well, part of the issue is, should it be equal? What should the relationship be? So this is a presentation from a few months ago to the subcommittee, created by the consultant that we've been using. And these two middle lines show that for 2024, so the current fiscal year that just started July 1st, it's projected that the Medicare age retirees, the costs are around $144 million. And the cost for those who retire, who are less than 65, but still retired and are eligible for and receiving healthcare benefits, is $134 million. That's within 10%. It's actually less than 10% difference in there. So why are we doing 100% of the changes for those who are receiving benefits at 65 or older, and not splitting it, 55-45 or something between the two? And frankly, why did the SCBC put all the changes on that 65 plus? So this is what I raised in the committee, and what we discussed briefly. We need to talk more is our work's not done. We're 4 or 5 months. I'm not suggesting we move the goalpost, but this is one reason why we're only aiming for 80%. Yeah, it was 80%, right? Yes, 80%. Because there's savings to be done elsewhere at that pre-Medicare retiree level, and we will not have time to make those decisions, but work can be done afterwards. The reason that there's a hard timeline is many of us expect right now retirees have the assurance, the promise, the commitment, the legal commitment that we have MedicFill through June 30th of next year. Most of us believe that that will be extended to December 31st of next year. You can't bank on that, but that's the expectation. So if that happens, and that's our expectation, then the state needs to be looking for somebody to provide that. Which way are we going here? There we go. Needs to provide that a new plan as of January 1st of 2025. So for it to be in place for January 25, it needs to be announced by June 1st of next year. And it need to have enrollment during October and November of next year. So if it has to be announced June 1st, needs to be agreed, has to be selected by the second calendar quarter, which means we need to receive the bids by the first calendar quarter, which means we need to ask for the bids late this year. And generally, you want to create that what's known as an RFP, a request for proposals, in September or October in order to have them flow in by January. So that means if we want to have any input on the next healthcare system, now this all depends on how the whole legal process and lawsuit goes. But if we want to have any reliable input, we need to have our recommendations in by the end of August, at the latest, the end of September, which is why our meetings are only projected to go through September. That is if we wish to affect the next choice, the next plan, assuming the courts at some point put the responsibility back on us to go through a process to select the next plan. We expect that, but frankly, there's two different opinions depending on what camp you're in as far as how the lawsuit will end up. So that's why there's a deadline, but it doesn't mean that our work has to stop there. Probably, I think we'll go back and do two things. One is we'll monitor the work of the SCBC. We'll talk about that in a minute. And the second is we may look at, do we want to do more than 80% by now making some changes to the pre-65 retiree benefits that we provide. So that's to be done, TBD. So the RHBAS may continue. The way that it was written, it was left open-ended, I think intentionally, so that we can build through that. And with that, I want to bring up, is that the one? I thought it was there. Nope. Okay, so let's try that one. Okay, I'm going to go one more. Okay, one more here. I'm going to go to engrossed. I know you can't see a thing, and that's exactly the way I want it. Okay, so I'm now going to bring this guy up. So this is Senate Bill 75. We passed in January. It set up the RHBAS, the Retiree Health Benefits Advisory Subcommittee. And the subcommittee has the following powers, duties, and functions. Public meetings. And frankly, we had half hour or more of very passionate and well-considered and well-presented public comment from many attendees. We had more attendees than we've ever had. And I really want to thank everyone who was able to come down and those who tuned in remotely and offered public comment. You were heard, and I think you saw that it really made an impact, your presence and your statements. So public comments about current and future state retiree healthcare benefits. That's the first thing, okay? Including things like Medicare Advantage. And we want to take into account past work from the SCBC and its previous subcommittee, Retirement Benefit Study Committee. In the course of work, we're going to consider how Medicare Advantage plans nationwide are reported and analyzed in relate to the terms, the previous, what they call the Diamond plan, Diamond State Plan. Study and review the fiscal impacts of extending the Medicaid program beyond January 1st of next year. And then, what kind of options could we do to provide strong state retiree benefits in a fiscally sustainable way, including considering, Medicare supplement as at least a choice, and have reports, have a report to the governor and the General Assembly, so that we report to the governor and General Assembly, but we are a subcommittee of the SCBC. So there's an inherent reporting to the SCBC, which you can argue is a largely executive body group. So it go into the governor automatically, it's the SCBC, but more importantly, we're a subcommittee of the SCBC, so any recommendations go there. Now that raises the issue of how do we make decisions? And what happens there is we have votes. So I want to find where the heck I put the makeup. There we go. All right. So let's first look at the RHBAS. We have 15 members there. So in order to pass any recommendations, make any committed decisions, we need a vote. And when you get at least 8 people to vote yes for it. So let's look at the role of, well, let's look at different groupings of members of the RHBAS. We have 4 legislators, one from each caucus, a House Democrat, a House Republican, Senate Democrat, Senate Republican. So that's 4 members from the legislature. I will say we hear a lot from the public. That's what elected officials do, especially those who are elected by a subset of people as opposed to statewide. We hear from our people in our district often. And frankly, every subcommittee member in the past week has probably received dozens of emails from retirees who reached out to share their very strong opinions often about Medicare Advantage. So that's 4 of them are legislators. We have 3 cabinet secretaries who report to the governor. So it's the Department of Human Resources, Department of Finance, and Department of and the Office of Management and Budget. So we got 3 you can say with the governor, 4 from the legislature. Then we have, I think it's 3 statewides. Is it 3? So we've got Lieutenant Governor Bethany Hall Long. She's the chair. We have Trinidad Navarro, who's statewide, the insurance commissioner. I think that's it. And then we have 5 retirees, 6 retirees. Well, now look at that. Excellent. 6 retirees. So 1 from each county, and then 1 from 3 different unions of state employees. So we've got those 6 who are retirees or represent retirees. We've got the 4 legislators, that's 10. We have 3 cabinet secretaries, that's 13. And then we have Lieutenant Governor and the insurance commissioner, that's 15. So I think the point I want to make here is this body is not a rubber stamp for the administration, for the governor, because the governor, while he appointed many of these people, such as the retirees, what you find when you're attending these, even if you're attending virtually, these subcommittee meetings, you are hearing from many of these different members really challenging some of the perspectives that were presented by the administration last year regarding Medicare Advantage. So I think we've got a pretty independent and very thoughtful and committed subcommittee here. And to get something done, we're going to need 8 votes. And, we have 2, 4, 6 retirees, both retirees and unions. And then, so you can say you can look at camps and say, where do we have camps? How can we get to 8? Assuming that the retirees, all 6 of those individuals, are not interested in Medicare Advantage, certainly as the only option, and maybe even as an option. That's 6. We need to find another 2. And we've got some good candidates there. So that's what's in the RHBAS. Now let's look at the SCBC, because that's just recommendations. The RHBAS just makes recommendations. Then we come to the SCBC. It only has 11 people on it. It has, so you can see my arrows. The first 2 in the left column and the second one in the right column, those 3 are cabinet secretaries. They are different secretaries from the last one, or 2 are the same, one's different. So that's 3 from the governor's side of things. This upper right is, I'm going to say, fairly independent. The Chief Justice, so Judiciary has 1 seat out of the 11. The other unique one here is Ruth Ann Miller, Controller General. We have an independent financial forecasting group in the legislature, so they're paid by the legislature. They do report to legislative leaders, but really fairly independent. So you can look at the Judiciary and the Controller General and say those are 2 fairly independent individuals. Again, you've got the 3 cabinet secretaries. Now, what else do you have? You have 3 statewide. You have the treasurer, the insurance commissioner, and the lieutenant governor. And then you have 3 retirees or representatives of retirees. So 3 retirees, 3 statewides. You've got 3 from the administration and then 2 semi-independent. And you need 6 in order to get a decision. Again, only 3 from the governor's office, cabinet secretaries and you need 6 to make a decision, SCBC. We changed this as part of SB 29 in January. We made it we changed the balance. The governor's office has a smaller number of seats on this body. I say that to say there's a lot of concern that whatever the RHBAS recommends, the SCBC may disregard it. Um, Absolutely possible. It's less possible because of the changes that the legislature made in SB 29, signed into law by the governor in January. So just want to throw that out there. The makeup matters. I still have no questions, which is fine. And I've been rambling for 50 minutes. Holy cow. Um, with that, our next meeting is August 10th. So we've got some time, for that, I guess more than 2 weeks away. We'll see where that goes. Please don't hesitate to reach out if you have any questions. I sent a response to the dozens of people who wrote me over the past week or so with an update. I also maintain a YouTube page where I store these Facebook Lives, because there's a lot of people who don't use Facebook, and that's all well and good. So if you know any of them who may be interested in this information, you can get them. You can just do a Google search. This is how I do it. Google search YouTube Representative Paul Bombach. And this page will come up. I'm sorry, this page. There we go. This page will come up, and you can see I've got somewhere around 10, 11 different updates on Delaware retiree health. And what I'd suggest is go there and get the latest one. So I did one about a week ago. This one I'll upload at the end. And so that is what's that's available to you and to others who want to see at least my updates on this. Any more questions on? Okay, I'm going to talk, Bob. I'll get that at the end. The tax rate is a contributing factor to climate change. Okay, so okay, we'll get that's not related to retiree health benefits. I'll still talk about it very briefly at the end. Any retiree health benefits questions at this time? And so, Bob, you talk about open space. I'm one of the two legislators who serves on the Open Space Council. Interestingly, and I'll say I'm excited to say that there is a commitment to purchase 250 more acres for the White Clay Creek State Park, which is the vast majority of that park is within the 23rd House District. We're really pleased about that. And that is one that has a lot of forest cover, very good for the environment, very good for Delaware residents. We have, I think our park system is rated somewhere around the second best in the nation, I think on a per square mile basis. And we've been putting $10 million a year, roughly, into the open space program for well over a decade, maybe even more than 20 years before my time is when it started. And that's been very effective. There's still, I have quarterly meetings, and we have parcels to consider, proposals to consider and explore, and that's where this recent purchase came from. Yes, Bob, it is great news for White Clay Creek State Park, and this has been something that a lot of the past open space purchases have been down in Kent and Sussex, because that's generally where more space is available, and we've been dedicating. In some cases, it's an easement where the current user, the current owner of it, has a lot of wooded acres on it, and we want to keep it that way. So we may purchase an easement so they cannot develop it. They have agreed to sell it for a certain dollar amount, and in return, they legally cannot redevelop it. They have to leave it as forest. In other cases, where we have a right to first refusal if and when they ever put it on the market. And other ones are just outright purchases. Most often when we do this is, I know we're going far afield, is that these are adjacent to other state forests and state parks. Bob, I can do more offline on open space. I want to keep this targeted to retirement. With that, thank you very much. I'm probably going to be off for maybe 2 weeks or more on the weekend updates due to travel. But please don't hesitate to reach out. My email's at the top of the list here. And thank you all for joining me. I hope you have a good, it's beautiful. Please hope you get to enjoy some time outside today and this week. Take care of it. Talk to you later.